today we will be presenting a case of facial trauma. Shall we start? Sir, a middle-aged around 38-year-old man was brought with alleged history of a road traffic accident.
What is the age?
38-year-old.
38-year-old.
Alleged history of road traffic accident. In my initial 10-second assessment, patient was very drowsy but trying to obey to my commands, but not fully oriented or obeying to my commands. And immediately I did my primary survey. In primary survey, airway is already the patient has been is having an oropharyngeal airway, size 4. Red color oropharyngeal airway was there, and but it was pooled with blood. Some blood was there, and there was other oral secretions like blood and mucous secretions were there. So I intervened that point itself. I did suctioning of the oral cavity and made the oral cavity.
How did you do the suction when the airway is in situ? And how did you pass the suction catheter?
Sir, suction catheter, we on the sections before turning on the section, we will be passing
the catheter tip into the oropharyngeal cavity. How did this happen? See, if it is said, you will open the mouth. Then you can directly put it. Now the oropharyngeal airway is in situ.
We will have to pass it through the oropharyngeal airway.
One is through the oropharyngeal, or if there is gap by the sides, we can go.
Okay. We can go through, sir.
Then when you are passing the catheter, was it going freely or is there any difficulty?
No, sir, it was going freely.
And because it will indicate any obstruction is there.
Yes.
Blood is clotted and too much obstruction, we can able to fill like the endotracheal tube checking. One of the way is passing the catheter, but it's not a foolproof method. Okay, good.
Full of secretions were there. We removed all the secretions, possible secretion, everything we removed. And after that, the oral cavity was patent for time being. Then I checked his cervicals. He was already
after putting section, did you examine the oropharyngeal cavity?
Since it was a severe facial injury, sir, so I only checked the oral airway patency only at that time. Since he was already secured with an oropharyngeal airway, and the patency of oropharyngeal airway alone was checked, sir. And oral secretion, oral cavity was also
whatever this thing, you can remove the oropharyngeal cavity airway, and then you have to. It is your duty to find out whether there is any internal injury, which is what is the extent, and is there any bleeding, what is the type of bleeding, okay, the continuous or heavy bleeding or mild oozing like that. Then only we can temporarily at least safeguard the airway. If we are missing this, further aspiration may be a chance. Okay.
Then cervical, he was already secured with a cervical collar from outside, so we didn't remove it. So then I went to the breathing part. He was achieving a saturation of only 88% in room air, sir. So I again went to the primary survey airway and I removed the oral cavity and started him on oral pharyngeal airway and looked for any oral injuries or ongoing bleedings or tongue fall, anything was there. But he was able to slightly obey to my commands, and in my examination there was no active bleeding or tongue fall at that time, sir. And so I started him on O2. Then I went to the
method of administration of oxygen. How did you supplemented oxygen? How you started O2? Yes, how it was administered?
Right now, I started him on face mask around with the NRBM 15 liter O2. We started him O2, sir.
Okay. So now you removed the oropharyngeal airway.
For time being, I was
temporarily
removed. And then I
did you hear any airway sounds?
No, sir. No gurgling or no hoarseness or no other audible signs that suggestive of an upper airway obstruction was audible at that.
Specific any snoring was there?
No, sir. No snoring.
Why an oral airway was applied? Was he a good candidate to have an oral airway?
No, sir. Ideally, oral airway is not preferred for patients who have preserved reflexes. I mean, gag reflexes. So, ideally, oropharyngeal airway is not indicated. But from an outside hospital, the patient has been referred with that. But
maybe at the time of assessment in that hospital, maybe his disease was low. That would be the reason they would have inserted an oral airway, and maybe for the suction and to maintain the patency of the airway. Anything else that you, from the examination of this patient, you find anything obvious for this patient when he came to the emergency room?
There was a massive, a big lacerated wound over his face, and in ophthalmos, the eye was almost sunken, and severe my oozing of blood was ongoing from
anything
the patient.
Else in the past? So you are anticipating a difficult airway.
Yes, sir.
Anatomically, anything else?
Short neck was there, mustache was there, but not beard, but fat person, obese person.
Obese, short neck.
Short neck.
Most important. Okay.
So,
So what is the possibility? What is the thing when the patient level of consciousness is altered? Short neck. What will be the problem with the airway? What do you anticipate?
In persons with short neck, especially patients with obesity, the chance of anatomical collapse is a possibility.
Tongue falling back.
Tongue fall is very high. In trauma with associated mandibular fracture and all, tongue fall possibility is again very high, sir. And in case of very low GCS also possibility of tongue fall. Along with in case of trauma, other aspiration, everything is a possibility.
Okay.
And other contributing factors, in case of obese patient, he will be having low reserve volume, and such kind of other metabolic and respiratory parameters also will lead to sudden hypoxia.
Okay, in such cases, see, an airway will definitely be of helpful. But here there is no question of nasopharyngeal airway.
No, sir.
Already the injured area.
Yes, sir.
So only option is two things. One, we have to go for oropharyngeal airway or supraglottic airway devices.
Yes, yes, sir.
So internally there is no bleeding, no injury, teeth are okay. So the patient, as long as still you are removing, the oropharyngeal airway was tolerated. So we can think of again putting the same size, or if you think it is little bigger, you can correct measurement, you can appropriate size oral airway, you can gently pause it, checking whether the patient is tolerating or not. Okay, that can be done. Somehow we have to make a patterned airway in this case. Otherwise, short neck, falling back of tongue, these are all causing profound and prolonged hypoxia will be there. So our oxygenation may not be reaching adequately to the alveoli. So still there will be partial airway obstruction, which can be overcome by this airway. Okay.
So how will you measure the oropharyngeal airway size?
Sir, measure from the angle of the mandible to the angle of the jaw. We have to measure the size, sir.
Angle of mouth?
Angle of mouth to the angle of the mandible, sir.
Okay.
We have to
how
measure.
will you measure the size of the cervical collar?
Cervical collar.
Cervical collar. Because whatever cervical collar, we only have like small, medium and large.
Yeah,
there are some universal cervical collars where you can adjust the size depending upon the patient's neck. Who will have a short neck, whether males or females?
Short neck or female?
More common with males. Usually males will have short neck, females will have long neck. So how will you measure the size of cervical collar? Maybe you have three hands from the angle of mandible to the shoulder, above the shoulder. You can just place it like this. So 3 finger or 4 finger, and the same thing you can go for the universal cervical collars, and you can adjust it accordingly. So usually in males maybe 3 finger, usually in males it will be 3 to 4, and females it will be more than 4. That's a usual scenario. But every patient you need to measure, and you need to find the correct size of cervical collar. So that is for the universal, where you can adjust the length of the cervical collar. Otherwise, whatever Philadelphia collar that we use, it will have small, medium and large. So depending upon the patient, you can use either one of this, either a medium or a large one. So the most important thing, you should select the correct size of the cervical collar. That is the most significant thing. Okay.
So also most important is oropharyngeal airway correct size selection is more important. So sooner you are removed, you could have whether it's correct size or not, or if you are thinking immediately, you can make another airways and check it whichever is the appropriate size and then pause it. What will happen if you are putting a smaller size or bigger size airway than expected?
If you are putting a smaller size airway, the chance of pushing our tongue backward and causing an obstruction is a possibility. Similarly, if you are putting a larger face, the chance of going into hitting the posterior pharyngeal wall and stimulating acroflex is very high.
See, okay, one more thing. See, you are stating that the patient is having short neck.
Yes, sir. Yes,
so what do you anticipate with reference to your RSI?
In case of short neck, we are expecting a little bit of difficult intubation.
So you have to keep in mind, just at the look of the patient, short neck, immediately, at any time you may be planning for an intubation. So you should keep in mind about this one. Okay.
Difficulty in back mask ventilation, what all you anticipate here?
For this patient, basically we have to again we can look for MON score, sir. That if the whether we are getting a proper mask seal or not. For this patient, there is a obvious facial injury, so possibility of getting a difficult mask will be an issue. Next is the obesity, of course. It's again
So what you
another.
can do in order to avoid this placing the mask? He had a laceration this side where the mask rightly fits in. So in that scenario, what you can do for the perfect fit of the mask?
One is we can use the inside of the oral cavity. We can seal it with our tongue itself if we are placing the mask inside, or we have to get a proper size of the mask. A smaller size should be used.
See, what are the precautions you have to take when you are doing a back mask ventilation?
Precautions, what we have to take is chance of
With respect to this patient.
This patient with respect to one is that chance of aspiration is very high.
Okay,
Patient
okay.
can have emesis at any time. Next is if there is associated severe maxillary fracture and all, if you are doing further ambu, chance of developing emphysematous chances development will be high. Pneumocephalus, everything will be very high. Other than that, sir, the major complication, aspiration.
See, the mask fitting should be correct, number one. Number two, when you are keeping the mask seal appropriately, no undue pressure over the eyeball. So already eyeball is enophthalmos, you are telling. So what is enophthalmos? We have to anticipate posterior orbital fracture and it's pushing it. So that will compromise optic nerve compression as well as the vessel which is supplying. So that may also be entangled. So vision may be badly affected. In addition, you are increasing the intraocular pressure by your mask, then it will be. Number two, you have to open the airway. You have taken the airway out. How will you open the airway?
Two
in this patient.
Either we can do the jaw thrust.
Jaw thrust. Did we do jaw thrust?
Since he was at that time obeying and he was able to protrude the tongue, I didn't have to do the maneuver. He was able to obey at that time. So.
Okay. So obeying, but there your anticipated airway obstruction is there. See, if you want to give jaw thrust, how will you hold the mask?
If you want to do the jaw thrust means we will have
and
to
then back mask.
We will be using our both fingers.
2%.
2%
are needed.
We will have to give the pressure below the mandibles and give forward. And
it's ideal. Okay, this is an ideal way to avoid oropharyngeal airway and then better oxygenation with any means. NRBM. Okay, then.
Different back mask technique can be asserted. Easy clamp method will be difficult for this patient because again mask seal won't be proper. So 2% is definitely needed for this patient for doing back mask ventilation. One with jaw thrust maneuver and holding, that will be the easier. And easy method will be difficult. So both the hands you can put.
We require proper seal. We will be using better to use both hand and. So for our patient, since in the breathing part there was desaturation, we started him on O2 and again we reassessed the primary survey. The airway he was maintaining, breathing his saturation.
Jonas, what happened to the saturation?
Saturation of breathing in saturation started improving. But at that time itself there was a transient some unresponsiveness. Patient developed an amount of unresponsiveness, possible Curie seizure, but there was no obvious jerky movements, motor activities were not detected. But suddenly patient went into a state of unresponsiveness. So a patient, we immediately intervened to secure the airway. We went for an emergency intubation, sir. Since we are expecting a difficult intubation, we have our difficult airway trolley also ready with all the backup for supraglottic airway devices and surgical airway if required. But we were able to intubate. We immediately gave the patient, since he even though he transiently went into complete unresponsiveness, he started to have again responses again. So we planned with a rapid sequence intubation with drugs. Anyway, as a pre-medication, we gave prokinetic agent, perinom was given at that time, and to give induction agents, we preferred ethomidate 0.3 mg per kg, and then analgesics, fentanyl was given, 50 to 75 microgram fentanyl was given, and along with the and after pre-oxygenation to paralyze the patient, we used the rocuronium, 50 mg was used, 0.9 mg per kg, and with the drugs we were actually able to in the first attempt also intubate the patient with a tube size of 8 size tube with the angle of mouth around 22, sir. and we were able to secure the airway.
So with the pre-oxygenation, what was the oxygen saturation response from the
with the
previous level?
Saturation we were able to achieve it between 99 to 100%.
Good. Okay, good.
This trauma patient again,
Yes, sir.
suddenly he became unresponsive. Before intubation, you want to rule out something?
Hypoglycemia, one thing.
Okay.
Next,
Before intubation, you want to...
pneumothorax, the chance of lung, everything we have to rule out.
It's a polytrauma victim, he doesn't know what is the status.
Yes, sir.
So whether it is due to pneumothorax, the hypoxia is not improving because as such, we are just seeing an upper airway obstruction and some bleed, and maybe you would have some aspiration. So definitely you need to look in for other reason why he's having hypoxia.
So even though I'm saying now, we did a parallel survey, we did our fast along with that, we auscultated, everything was done simultaneously, sir. But gradually I will take.
So breathing was normal.
Breathing, initially because of secretion he was having some struggles, but after proper suctioning and clearing he was better.
Adequate chest rise and fall, and then air entry. Breath sounds are heard all over this.
Yes.
So what would be the reasons why you went ahead with an intubation? Can you just tell few of the reasons? When you just look into this where you don't have an RSI facility, whether we definitely wanted to go ahead with an RSI, what is the reason why we went ahead with an RSI here?
One is because of hypoxia that might have settled because of the secretions and pooling, and initially saturation was also low. One is that upper airway obstruction. Second possibility, this oropharyngeal airway is self-causing any vasovagal reflux or something. Third option is it's a trauma case, possibility of intracranial bleed or intracranial insult is there that might have developed into seizures. And other possibility.
So we are anticipating and decreasing or a problem with the patency of the airway. That is the more important thing. And again, hypoxia was also there, but initially you think hypoxia is due to the patency, decrease in the patency of the airway related to the secretion, malposition of the oropharyngeal airway, maybe secretion that you have blocked, or maybe you have not the position, the neck was in a neutral position. That could be the reason. And also you have ruled out a chest injury.
Yes.
So hypoxia primarily looks like a reason with the airway, upper airway and lower airway. Some amount of aspiration also happened. And he also had an episode of brief unconsciousness.
Yes.
And also you need to take this patient to outside your emergency room for investigation. So definitely it is an anticipated problem with the airway is going to happen in maybe in the next 1 or 2 hours. So in order to prevent that, we have done the went ahead with the RSI. Anything else, sir?
See, the patient was responding to your commands. See, a transient and a period of unconsciousness, then immediately he recovered. What was the status?
Even though he recovered means that
Yes,
he was not fully conscious oriented.
Not
sir.
conscious. Not
GCS of
responding
hardly
to
around
verbal
E3, V2, M5 that range.
Not to say that GCS was not less than 8,
8 than 8,
but above 8.
Above 8.
So
Above 8.
not for an definitely intubation, GCS was not there, but because of this aspiration, bleeding, and with the 12 GCS, it is always better to secure the airway. He need to go out of the emergency room.
Aspiration and ongoing bleed, it was
See, in improving the oxygenation, in such type of patient, we can do 2 things. Provided the first is positioning the patient. If the patient is for base short neck, we can give a proper position. So that will be avoiding the splinting of the diaphragm by the intestines, abdominal contents. Number 2, if the patient is conscious enough and he can obey commands, we give oxygen by NRBM and encourage the patient to take deep breath as much as possible. Constantly going on repeating. So definitely this will be achieving very high percentage in shortest time. So we need not have to assist the ventilation also, provided the patient is obeying commands. The position we can put any patient like that.
So that was regarding breathing. And then I went to the circulation. As I mentioned, he was maintaining the BP 120 per 80 millimeters, but tachycardia was there around 124, possible because of pain. Then I went to the disability. GCS was around initial when he came, his GCS around E3, VT, and his oropharyngeal airway is there at M5. But after we removing, his GCS transiently improved around E3, V3, M5. But then post intubation, it was E1, VT, M1. Pupils, when he came initially, the right side pupils was almost 3 mm dilated, 3 to 3-4 mm dilated, and it was only sluggishly reacting. Left mm was 1.5 mm equally reacting, sir. And GRBS was also checked, it was around 98 milligrams per deciliter was there. and the peripheries were warm, not cold, and anyway we covered him with warm blanket was given, sir. So as I reassessed the primary survey, now post intubation he was maintaining saturation, no severe active bleeding was there, he was maintaining the primary survey. So as an adjunct I asked for an since there was associated hypoxia injury and all, hypoxia episodes and all, I asked for an ABG was asked, along with an ultrasound fast was done, and also an X-ray chest and pelvis was also ordered, and he was an obvious injury itself, there was facial injury, and plan for a cervical wall spine screening along with CT brain and facial bone screening seating was planned as an adjunct, sir. In our ABG it came, ABG was showing an pH of only 7.247 with PCO2 40, PO2 was 100, bicarb of 16, and SO2 90%, lactate was 4.6. So patient is having a non-compensated metabolic acidosis, probably because of muscle injury or possible because of seizures, possible. So anyway, at that time we started him, since there was no associated hypotension and all, we didn't give him any fluids. We are planning for, anyway patient might end up in a surgery, so we kept him NPO. For that we started him only maintenance fluid only was started with a normal saline, and along with that we gave him, as per crash show trial, we gave him tranexamic acid 1 gram was given over 10 minutes, along with the maintenance of tranexamic acid 1 gram over 8 hours was started, and since he was analgesia was already given along with the intubation, and frequently it was reassessed.
So what is the indication for tranexamic acid?
Tranexamic acid, any patients with traumatic bleeding, as per the crash 2 trial we can administer tranexamic acid is found to be
here maybe
external oozing of blood was ongoing, sir.
It's ongoing. Okay.
Ongoing, sir. And by this time we planned for shifting, since the airway primary survey is patent, we asked the patient to shift him for neuroimaging along with the thoracic and pelvic X-ray was also done. Fast was found to be negative, extended fast was found to be negative, and then I went to the, I will tell the secondary survey. In the secondary survey,
as per ATLS, where does the CT brain will come?
CT brain.
Is it the part of an adjunct to the primary survey?
The part of adjunct survey only X-ray, chest and pelvis.
Usually it is a part of the adjunct to the secondary survey. So actually for this patient, his priority will be a life-threatening emergency. What will happen? It will be to the brain. Or to the maxillofacial, and most importantly his eyeball. Because whatever possible, we have to preserve the vision.
Yes.
So rather than we can say that it's not a limb-threatening injury as such. Life-threatening may not be there, but it is obviously an eye-threatening or the vision-threatening injury that has happened to him. So as a part of the adjunct to the primary survey itself, he has went to the CT. Because you didn't had a complete, you would have scanned the patient completely, but obviously that was a priority for this patient, because obviously there was no other external injuries and you had quickly done your full body scanning. Fine.
So the result of the imaging I will tell the end. Secondary survey I will tell. In secondary survey, signs and symptoms I have already mentioned what are his presenting issues, and no history of any allergies from the bystander, from the history from the bystander, no history of allergies. He was not on any medications, and no relevant past history also. Even lead to is that it is an alleged history of road traffic accident. Patient was riding a bike and he was the person who was driving, and he was wearing a helmet, but with an he was coming from an overnight shift duty, and when he jumped over a road hump, he accidentally lost control and went and hit his head over the side post, and following which the helmet has broken and caused the severe lacerated wound over his right side of face. He was taken to a ESI nearby hospital, where he was quickly evaluated and immediately referred to here. But no history of any seizures or no history of any vomiting, no history of LOC was there. Then I went to the heterophoto examination. In that I will focus on the facial injury.
Any alcohol consumption or drugs, anything?
From the history it's not there.
No history,
but from the
previous
examination, previous duty.
Previous night duty, he is finishing his duty by 7 o'clock and he was returning to his home.
Okay.
Not sure.
Not sure.
So I will focus on the facial injuries. So first and foremost is to do the inspection. So infection, there are major facial injury fractures. Entire facial injuries, either it is in the associated with the zygoma or the eyeball, or it will be associated by the midface, or it will be associated by the mandibular fracture. So in inspection itself, sometimes we will be able to see in this patient itself any depressed fractures visible in the frontal bone was there, but there was no visible fractures, but there was depressed ophthalmos was there, depressed zygoma was also there. So and in such view we can go for different views. In lateral view we look for any dish face appearance is there, which is seen in case of Lefort 3. No sir, this is actually to see the patient from side.
Inspection
itself. Okay. It is seen in Lefort 3. The entire face will be depressed. In the front view there is something known as donkey's view. It also suggests of Lefort 3 or 2 type of fractures. And another is bird's eye view, which we can look from the above of the patient. In that case we can look for exophthalmos, and if you are looking from below, that is worm's view, then suggestive of inophthalmos. For our patient was having inophthalmos, and look for any raccoon eye or any visible laceration. For our patient there was a big laceration around 8 centimeter length, 1 centimeter width and 1 centimeter depth was there, and ongoing oozing was there. And then we can go for the palpation. And palpation is that to look for any step deformity. For example, any zygomatic fracture or mandibular fractures, we will be able to look for any step deformities there or not. Next is feel for any crepitus, any maxillary injuries. There will be chance of escape, and it will be there. Next is look for the TM joint dislocation or anything. We can feel for whether the patient is able to open his mouth or not. In case of mandibular fracture, such a possibility of condylar dislocation or a fracture will be also there. In that case, we can place the finger in external auditory matters and ask the patient to move. In condylar fractures and all, we will be able to feel the crepitus. One more thing, in the inspection, we should look for any base of skull fracture also. Just like I mentioned, raccoon eye, any CSF rhinorrhea, or any hematoma, any master battle sign, anything is present or not.
Which is the most common site of fracture for mandible?
Mandible, this angle of
condylar.
Condylar.
Approximately around 30% of the fracture mandibular condylar, and I think it is the ramus. That's the most common area that we have the fractures. Then what are the other inspectory findings that you can ask for?
Patient bite will be improper. Patient won't be able to bite properly. Proper fitting won't be there, and sometimes obvious deviation of the mandible might also be there, sir.
But when suddenly in your inspection, you will not be able to appreciate the bite. When you are able to ask them to move and do a proper bite only, you will understand it. So bite is very important.
Bite and test is also there, right? Then we have to properly examine the eyes also. We have, if possible, we should be able to document the visual acuity if possible or not, and look for pupillary reflex. Our patient, I already mentioned the pupillary reflex, but we were also able to in ophthalmic eye, but no visible penetrating injury were there, but hyphema was there. Hyphema suggests of internal bleeding is there. Hyphema was there, and in case of globe rupture, teardrop sign will be there for the pupils, but it was absent for our patient. And sometimes that's what regarding. Then regarding nose, always look for these nasal septal hematoma, because if it is not timely intervened, chance of pressure necrosis will be very high. And look for any CSF leak, but CSF leak, it is very difficult to identify between it is a rhinorrhea or a CSF leak. We have to check for beta-2 transferrin and confirm whether it is a CSF with. We can look for a handkerchief test, and double ring RSS will be there. And yes, we look for hemotemphanum or CSF leak and auricular hematoma, anything is there or not, we have to inspect, sir. And definitely we have to look for the oral cavity. Oral cavity, any visible lacerations, any missing tooth is very important, because the chance of that aspiration, everything will be there. In case of missing tooth, we should always go and properly examine the X-ray chest, because the possibility of aspiration is there. And malocclusion, then possibility of Lefort fractures should be thought, and tongue blade test. That is a test in which the proper closing and geometric muscle functioning is there. We can ask the blade, and the patient is able to break the blade, which means it is intact. So this is regarding the gross inspection. And since it is a facial trauma, I will speak a little bit about the mid-facial fractures also.
Any cranial nerve that you need to examine?
Always the third and second and third olfaction it should be there. Then trigeminal nerve injury should be also be suspected.
Sensory or
Trigeminal sensation will be involved.
so which part you will
Many areas are there. One is in the occipital area, in the frontal bone is going, it is supraorbital nerve injury. If the malar area are going, infraorbital nerve is there. Mental nerve will be involving the chin and all, and trigeminal nerve will be the cheek and all.
Okay.
This will be the gross nerve injury that we should look for. And
it's the CT finding for this patient.
Our
So the discussion will be more effective.
Lifford fracture classification.
You can just come back after what this patient had.
Okay. Our patient CT brain was normal. There was no intracranial bleed. CT facial bone, there is a fracture of right zygomatic process, multiple fractures of right zygomatic process, and medial wall and lateral wall of the orbital fracture was there. Roof of right maxillary fracture was there, and protrusion of the fat from the orbital cavity into the right maxilla is there. That is why the patient has gone into enophthalmos. So otherwise CT wall spine screening was appearing to be normal.
Most importantly, when somebody is having such a facial injury, obviously they will be having cervical spine injury. But luckily, this patient had a mechanism injury of a direct impact to the face, and he has escaped with the cervical spine injury. Usually, around 50 to 60% of the patient with this much severe maxillofacial injuries will definitely have a cervical spine injury and also a head injury. But this patient has got an isolated maxillofacial injuries.
Yes, sir.
And orbital, maxilla, and facial bone
Fracture.
We can tell about the classification where we can place this fracture as such. Will we be able to name this fracture? No. Unlikely.
Our patient is not possible, but most common associated is the zygomatico-maxillary complex fracture. In that, zygomatica fracture and lateral orbital fracture, inferior orbital fracture, and the lateral wall of maxillary sinus fractures will be usually
we can call it zygomatico-maxillary complex fracture. But I don't think we can name exactly, but it is involving the zygomatic maxilla and the lateral wall of the orbit, not the inferior orbital.
Even though medial and lateral orbital blowout is there, we can call orbital blowout fracture can be called. So I just mentioned the midfacial injuries also. Nowadays midfacial injuries are less common because of proper restraining systems available in our vehicles. But if it is associated with the midfacial injury, the patient will have profuse bleeding from the nasal cavity and oral cavity. So basically it is 4 types are there. In Lifford 1 means it is a transverse fracture and it separates only the body of the maxilla. So how we can test is that we can with one hand move hold the hand, and with the other hand try to manipulate the hard palate. So only the tooth and the central part of maxilla will be moving in Lifford 1. It is least severe compared to other two. In Lifford 2 is a pyramidal fracture where except the eye, the entire nose will be involved, and the hard tooth, everything will be involved. Center part of maxilla along with the base of the nose is fractured. So movement will be including the nasal septum, we will be able to manipulate. Lifford 3 means the entire face has been disconnected from the skull. So including the orbit, everything will be movable. Actually the only thing that will be connecting the face and the brain skull will be the optic nerve. Optic nerve will be holding this.
The other name, Lifford 3, craniofacial
distinction.
So that is the name of the fracture. There is no connection between the cranium and the facial nerve. As you said, it's only connected with the optic nerve. So that is and Lifford 3. Lifford
4 is same as Lifford 3 along with the involvement of frontal bone. That is Lifford 4 classification. And then we have to look for the lower part, mandibular fractures. We are just like mentioned, any step deformity is there or not, any deviation to any side is there, whether patient is able to clench properly, and also feel for any dislocation features, and also into the oral cavity. If in the auditory meatus. And if the patient is found to be normal, then we can apply for Barton's bandage also can be applied in suspected mandibular fractures.
Mandibular fractures usually won't be an urgent emergency. It is not needed usually.
So isolated mandibular fracture, before going for CT, it is highly sensitive to go for panoramic X-ray view can be taken for mandibular fracture.
Any other views that X-rays that we can do for any of the facial injuries?
Then Waters view is they are suggesting, but if there is obvious injury, they are asking to go ahead directly with the CT of the facial bones. But in mandible, before going CT, they are advising sensitivity. OM15, OM13s are there to look for zygomatico-maxillary complex fractures where the head is kept at 15 degree and 13 degree is there.
That is just for the sake of completion. But always it is better to go ahead with the CT
ATLS
with the 1 mm cuts so that you will be able to see the facial fractures exactly.
So this was the our head to foot major examination regarding the this. Otherwise, his musculoskeletal examination and other systems were within normal limit. Only other positive finding was there was a lacerated wound over his thigh. That was his only positive finding.
What was done to the wound here?
Wound
It's an open fracture with an external.
So from our emergency side, we gave him proper saline toileting was done, and along with we gave him TT was given, TT prophylaxis was given, along with the tetglobin 50 international unit was given, and we gave first dose of antibiotic also. TLS is suggesting cefuroxime 1.5 gram, and initially we suspected a globe rupture because before CT it was an ophthalmic possible, so we to cover anaerobic we gave metrogel also.
Optic nerve injury.
Optic nerve injury. We have to otherwise give steroids also. As in case of suspected, as initially pupillar reflex were very asymmetrical. In suspected optic nerve injury, we can give Dexone also.
Either prednisone is a choice.
Choice.
Dexone also can be.
Yeah.
Any wound dressing did you do temporarily?
No, sir, later the patient was taken to the operation theatre.
Later not. Till we are keeping it open.
Covering with the saline.
That's what temporarily saline used because sterile gauze pieces can be kept. So eye protection.
Eye protection also. That hard flap have been applied, sir.
Yeah, applied, or you can just say wet gauzes. Don't use dry gauzes. And see that it is always lubricated, or else dryness should be avoided. Corneal aberrations may be there, and pressure. So you have to look for the neck also for any airway injuries, larynx or trachea. Again, this also should be part and parcel.
He was taken later, admitted into neurosurgery and combined with Maxillofacial surgeon team, and he was taken to for proper repair and plastic surgery assistance for proper suturing of the facial injury.
Okay. Thank you.